Hi guys, welcome to Take 1 Interactive Video Modules. Today's module will be about restrictive pulmonary disorders. You'll need a pen and paper handy to answer questions along the way. These questions will be collected for preparatory marks at the beginning of the next lecture. So pay attention. So today's objective will be to understand the basic pathophysiology of restrictive lung disease. So this will include intrinsic, which basically means stuff happening inside the lungs. So you can think of scarring inside the lungs. It could be extrinsic, which is stuff happening outside the lungs. So you can think of rib fracture or pleural dysfunction, anything that's putting pressure on the lungs from the outside. And we'll also talk about lung cancer today, as this can be thought of as a type of restrictive disorder, as it is compressing the tumor, compress lung tissue, and there's other reasons. Some of the treatment actually causes also restrictive disorder. So we'll talk about that. So for the conditions on the last slide, students will be expected to outline medical management of these conditions and the implications for physiotherapy technologists, as well as describe the rationale behind rehab interventions for these conditions, including methodology and contraindications, although these will be covered in the lab material. So please refer to the lab theory PowerPoint for these details. So to recap, restrictive lung disease, which I'll refer to as RLD for the rest of the presentation, can affect the parenchyma of the lung, which is this spongy tissue that makes up the bulk of the air exchange surface of the lung. That is called intrinsic disease. So that's what you see here on the left part of this slide. On the right, you'll see the extraparenchymal diseases, which is anything outside of the lung itself. So this can also be referred to as extrinsic disease. You see here disorders of the pleura, disorders of the chest wall, including many orthopedic disorders such as trauma, kyphoscoliosis, AS, etc. And you'll see disorders of the abdomen, which can include severe distension, hiatus hernia, morbid obesity can fall into there as well. The two main features of restrictive lung disease are difficulty expanding the lungs and reduction in lung volumes. The causes, potential causes, are listed here on the right. Please write down as your first prep assignment the numbers 1 through 4 and write down whether each of these will be considered an intrinsic or an extrinsic cause of restrictive disease. So write down 1, 2, 3, and 4, and then just write the words intrinsic or extrinsic next to the numbers. And when you're finished, you can move on to the next slide. So intrinsic restrictive lung disease can also be referred to as interstitial lung disease or interstitial pulmonary fibrosis, or IPF. This can be caused by exposure to environmental inorganic dusts. It can be idiopathic, meaning nobody really understands what causes it, or it can have systemic causes, which are often related to autoimmune diseases. Some characteristics are stiffening of the parenchyma, which is this tissue here. You can see how it's the alveolar walls have gotten quite thick and irregular. The distal air spaces become fibrosed and stiff due to increased fibroblastic activity and an abnormal healing response. So this leads to decreased lung compliance and decreased lung volume, which is exactly the opposite of what's happening with obstructive lung disease. And eventually these diseases can lead to respiratory failure. Write number 5 on your prep sheet and answer the following question. Obstructive lung disease and restrictive lung disease can both reduce gas exchange at the alveolar level, but it happens through very different pathological processes. Explain the difference between the pathology of reduced gas exchange for obstructive versus restrictive disease. So the first type of interstitial lung disease we'll look at is pneumoconiosis. This is commonly known as coal lung or black lung because most people have a history of exposure to coal dust through their work. So here you can see a cross-section of lung tissue from a healthy 90-year-old school teacher with no history of exposure to toxins. And then here on the right you see the massive fibrosis of a 40-year-old coal miner. So you can see this is really quite devastating. It's become much less common over the past 30 or 40 years in North America, just because they're doing a lot less coal mining, but still very common in certain parts of the developing world, such as China. So the second type of interstitial lung disease we'll look at is idiopathic pulmonary fibrosis, which means the cause is poorly understood. Risk factors include a history of smoking and exposure to metal or wood dusts, but there appears to be a genetic component as well involving an abnormal healing response. IPF has a very poor prognosis. It's a fairly rare compared to, say, COPD, but the majority of people diagnosed with it will die within a few years. They have been candidates for lung transplant often in the past, but unfortunately they often do have poor outcomes as the new lungs can be attacked by the same disease process. So here you can see the thickening of the alveolar walls we talked about, similar to pneumoconiosis, and the scarring and thickening of the parenchymal lung tissue. The next four types of interstitial lung disease include sarcoidosis, lupus, rheumatoid arthritis, and scleroderma. All fall into the category of systemic, rheumatological, or inflammatory disorders that have a detrimental effect on the lungs. So the first one, sarcoidosis, is a granulomatous disorder, meaning scarring in the form of small, walled-off inflammatory nodules. On the upside, it's often, it can resolve on its own, but those afflicted may be left with some residual scarring. So you can see here the little granulomas in the lung, and they often will also have enlarged lymph nodes related to the immune response. Rheumatoid arthritis is an autoimmune disease known for causing systemic inflammation in multiple peripheral joints. What many people don't know is that it can also affect the lungs, causing IPF in about 40% of patients. Pleural inflammation and effusions are also quite common, so you can think of this like a double whammy in terms of causing restrictive disease. So you may be seeing patients with this disorder for their peripheral joint problems, but you got to think about the potential impact on the lungs. Even if you're not directly working with it, it can have a big impact on your interventions. So what you can see here in the picture is, first of all, that the diaphragm is sitting quite high, and that these lungs are quite restricted, and also these interstitial markings, these white markings throughout the lung, indicating scar tissue. Systemic lupus erythematosus is a systemic autoimmune collagen vascular disease that attacks the lungs in 50 to 90% of patients. The pleura is affected more often in the interstitial spaces, but both can be involved. So again, you've got a bit of a double whammy. So scleroderma is also a systemic connective tissue disease that affects multiple organs, the worst being the skin, where it causes thickening and fibrosis of connective tissue. 2/3 of patients will also have pulmonary involvement, and many will actually die from this. The scarring within the lungs causes a restrictive impairment with impaired diffusion of gases, but the tightening of the skin and other collagenous tissues around the thorax can also be a cause of restriction. You can see in the image here the narrow aspect, the narrowing of the lower rib cage. As you can imagine, that would make it quite difficult to breathe. Some patients will also have increased mucoid secretion, so you might see some signs and symptoms of obstructive disease as well, such as coughing, wheezing, or crackling on auscultation. So what do patients look like when they have restrictive lung disease? Like in advanced obstructive disease, you may see an increased respiratory rate, severe dyspnea, and signs of respiratory distress or hypoxia, as you'll see in the picture over here. However, they will have limited chest expansion, especially when asked to inspire maximally. On X-ray, you'll see those diffuse white markings like you'll see here on the right. And as well, you'll notice the decreased size of the thoracic cavity, the high hemidiaphragms. So here, if you recall the difference between the normal and obstructive lung volume and capacity, these types of diagrams that we looked at last week for obstructive disease, now we can observe what happens with restrictive disease. So first, I'd like to point out that the tidal volume and the residual volume are relatively maintained. So for your next question on your prep assignment, number 6, question number 6, write down on your prep assignment, and I would like you to note A, which volumes are most affected in restrictive disease. So these are the volumes here. So I'd like you to write down which volumes are most affected, and consequently, which capacities are affected or drastically different for restrictive lung disease. And you can find this on the next slide as well. So click forward to the next slide to see this written down. So as promised, here's question number 6. I'd like you to note which volumes are most affected in restrictive disease, A. Consequently, which capacities in the diagram are also affected? You can refer to the previous slide as necessary. And what do you think the functional impact will be on patients in terms of tolerance to exercise? So what do the doctors do for restrictive lung disease? Well, seeing how most of the disease processes are inflammatory, the first line of treatment is often anti-inflammatory, and most often corticosteroids, though sometimes other types are used. So why is this relevant for us? Well, we know that prolonged use of corticosteroids may cause osteoporosis, leading to increased risk of fractures. So this is important to remember when planning treatment interventions. Now, related to the autoimmune nature of most restrictive diseases, immunosuppressive therapy is also often tried. The thing to remember about this is that it leaves patient at higher risk of infection. And also of note is that unlike in COPD, the meds are often taken orally. Also, high flow O2 is often used in the late stages, as hypoxia is very common, and some of these patients may actually be candidates for lung transplant. So, new set of lungs. Please answer number 7, question 7, A, B, and C on your prep sheet before proceeding to the following slide. So basically the goal with restrictive disease is to increase the inspiratory volumes, to increase the mobility of the thorax and surrounding musculature, to increase the strength of the musculature to fight against all of that stiffness, and then to decrease the respiratory rate in order to increase the length of that inspiratory cycle to give them time to get more air in. So how are we going to do all these things? Well, we're going to see that downstairs in the lab, mostly today. So if we come back to our initial diagram, now we're going to look at extrinsic causes, extraparenchymal causes of restrictive lung disease, which can be seen on the right side of the screen. Whoop. So basically, orthopedic problems can also be a cause of restrictive lung disease by restricting compliance of the thoracic cage and thereby restricting lung volumes. So the major acute orthopedic cause of RLD would be rib fractures or trauma to the chest wall. So in the acute stages, it's important to help patients maintain lung volume despite their discomfort, because they are at risk for atelectasis and for pneumonia if this doesn't happen. So one way to do this is to encourage diaphragmatic breathing patterns in order to maintain ventilation through the bottom of the lungs while avoiding excess movement at the injury site, which is higher up. So we'll also learn about how you can splint the area if your patients need to cough. So we'll see that downstairs. So certain chronic orthopedic conditions can also cause restrictive disorders by compressing lung tissue. So here the focus is usually restoring or improving thoracic mobility, just as much as the disease process will allow us to do. But in cases of severe or fixed thoracic deformities, you can see in both of these two pictures, it may be wiser to focus on diaphragmatic excursion, respiratory muscle strength, and balance, as well as postural education and external support as needed. So whether it's splinting or wheelchair support, or whatever is required to prevent worsening of the orthopedic problem. So to recap, in acute orthopedic problems, we primarily want to maintain volumes in order to avoid atelectasis or other consequences such as pneumonia, decreased ventilation. In chronic orthopedic problems, the goal is to maximize or increase volumes as much as possible depending on the particular pathology involved and how advanced it is. For the methodology of treating restrictive lung disease, refer to your notes from loss of mobility, spine and pelvis. We will draw on and add to these techniques and exercises in the ventilatory exercises lab downstairs. It should be noted that neuromuscular problems can also lead to restrictive lung disease. So pictured here are breathing patterns that may be seen in the presence of severe neuromuscular disease. For example, on the left, with severe intercostal muscle weakness, you may see inward chest wall movement, and that's because the outward abdominal movement due to the action of the diaphragm actually ends up creating a negative pressure and sucking in the chest wall without those intercostal muscles to your external intercostals that are balancing that by also pulling out the chest wall. So this is what you don't have happening, and so this is what ends up happening right here. So on the right, you have the opposite. You've got diaphragm weakness, so this isn't working. This is gone. And so if you have your intercostals working properly, that creates this negative pressure, and it actually sucks the diaphragm up and sucks the abdomen in. So this is called paradoxical breathing patterns. And these kinds of breathing patterns you'll only see in the presence of severe neuromuscular disorders like these ones: Guillain-Barré, ALS, high cervical spinal cord injury, and muscular dystrophies. You have to excuse my pen writing. I'm getting used to this pen. So pleural dysfunction can also lead to the restriction of lung tissue. There are a few different types that are possible. You can have pleural effusion, which is basically an inflammation of the intrapleural space. So if you think of the pleural like a bursa, then you can think of a pleural effusion like a bursitis. It's just swelling in that space. So empyema is very similar, except instead of being filled with thin fluid, that space is filled with pus, usually due to some kind of infectious process. And the other possibilities, you can have a pneumothorax where the intrapleural space is actually filled with lung that's escaped from the lung tissue due to a puncture right here, where you see on the pleura that's lining the lung tissue. So the air escapes out of the lung and goes into that intrapleural space, and therefore the lung tissue itself will collapse. So of note with this is that rehab is contraindicated until the problem is fully resolved. And you also want to be careful long term with any techniques involving large pressures, as there is an increased risk of recurrence. So inspiratory muscle training, for example, we're not going to do that with these patients, even once it's healed. So how is pleural effusion treated medically? Well, usually with a chest tube or a needle, which is called thoracentesis, to drain the fluid out of the lungs. So this could be left in for a few days if necessary, and for chronic conditions, a small tube may be left in place for repeat drainage procedures. So you can see the entry here, which we'll see a little better on the next slide. So this is what the chest tube looks like up close. You see the entry point here, and it can be used to drain air or fluid out of the pleural space. A couple points to remember if you are involved in mobilizing patients with chest tubes are to keep the bag below chest height, and of course to avoid removing the tube. Your patients will like you much better, and so will the nurses. So what can we do? Well, for pneumothorax, not much. What we want to remember about that is that we don't treat it. So if you see a new diagnosis for a pneumothorax, you'll want to wait until you get medical clearance to mobilize that patient once that pneumothorax is fully resolved. For pleural effusion, we focus on deep breathing and mobilizing the patient, similar as we would do for any sort of acute type restrictive lung disease. So now we're going to do a very brief overview of lung cancer because it is quite common. Of the cancers, it's the most common, and it's also the most deadly of the cancers. So I think it is important to talk about it. Here's just an image of a squamous cell lung cancer. So there are two types of lung cancer. The first one is a small cell lung cancer, and the second is non-small cell, which is the rest of the cancers. So you'll see these in medical files. The small cell lung cancers are much more aggressive, and they can be fatal really quite quickly, and they're not as operable. So the prognosis is much more dim for this diagnosis. So the image on this slide is a little bit shocking, but this gentleman chose to publicize his story because he wanted people to understand the risks of smoking and lung disease. And I wanted you to see this slide because it really shows how quickly things can deteriorate with lung cancer and how devastating the disease can be. So you'll see severe deconditioning with extreme weight loss, patients that are generally very emaciated, unwell. They may have really severe dyspnea with cough, tightness in the rib cage, and they just look sort of gray. So the best treatment for lung cancer is really not a treatment, it's prevention. As 80% of cases are estimated to be related to smoking, which makes it a very preventable disease for the majority of patients. So Public Health Canada has had ongoing campaigns to reduce the amount of smokers, the number of smokers, which has worked in certain demographics, and in other demographics of the population not so well. But we have a role to play. So, but I'm not going to say more of that because we're going to do, this is going to be one of the topics for your health promo presentation. So what do the doctors do for lung cancer? Well, whenever they can, they try to cut it out. So you might see a wedge resection, which is taking out a little piece of the lung, as you can see here. You might see a segmental resection, where they're taking an entire bronchopulmonary segment. You might see a lobectomy, which they're taking out the whole section of the lung, and I'll talk to you, we'll have that, one of your case studies will be a patient who had a lobectomy. And pneumonectomy is where they're removing the entire lung, which is quite drastic, but it can be done. I haven't seen one, but reportedly the lung tissue from the other side will sort of fill in some of the space, and anyway. So that's that. That's what the docs do. They cut it out. That's one of the things they do. But you can imagine, the restrictive disorder that you end up with after you take out a big chunk of lung tissue, that you've got significantly reduced volumes. So the other thing the docs can do is they can radiate the tumors. So they use radiation therapy, which is given, the treatments are given in a 4 to 6 week period. The dosage is given in gray. It's described in gray. That's the units that they use. There are a lot of side effects, and the slogan for physiotherapy during this time is radiation is a time to maintain, not gain. So it doesn't mean you have to stop, but it's just not a time that you're going to push patients in terms of exercise. Other things to note is that the area that's been irradiated can be fragile for up to 12 months post-treatment. They have to avoid any kind of manual therapy, deep massage around the area. Sunburn can also be very dangerous for these people. Oop. Okay. So as you may know, lung cancer patients may also be treated with chemotherapy, which is drug therapy. But in order to target cancer cells, healthy tissue is often affected as well. So the side effects can be quite severe, and the drugs themselves can actually also cause interstitial lung disease. So unfortunately, the treatment causes problems as well as the disease. So in terms of the pathophysiology of lung cancer, you've got the tumor compressing the surrounding lungs, so you have the restrictive component of the disease, but you may also have some obstructive component of the disease, because if you have tumors, they may actually be blocking airways. It's not the kind that we can treat. Obviously, our airway clearance techniques are not going to work for tumor, but you may have some of the symptoms from obstructive disease as well, wheezing, etc. And patients also often have COPD or maybe interstitial disease because the risk factors are shared. So most of the people with lung cancer are heavy smokers, and so they may also have some COPD or IPF happening as well. Restrictive disorders can be caused by, in lung cancer, caused by the disease itself, by the tumor, but also by all of the medical treatments that are performed. So if you look through the preceding slides and see how the various medical treatments may cause restrictive disorders. And you're going to write that. That's going to be your question 8 on the next slide. Please answer number 7, question 7, A, B, and C on your prep sheet before proceeding to the following slide. So what do we do for lung cancer? Well, first of all, I'd like to point out that we may not use percussions or vibrations in the presence of lung cancer. It is a written precaution here, but I would say it's a contraindication due to risk of metastases and bleeding. So what can we do? Well, we can exercise. So exercise has been shown to be effective in almost all types of cancer in the various stages of cancer. So 6-minute walk distance peak cycling load increased significantly in lung cancer patients after an intensive 8-week multidisciplinary inpatient rehab program. So and patients who did pre-op pulmonary rehab prior to having their wedge resection or lobectomy or whatever had a significantly better post-op course. So exercise is very useful in this patient population. But one thing we have to be very careful about when we are exercising or mobilizing these people is that they are at very high risk for bone metastases. So especially if they have known metastatic cancer. So they have a very high fracture risk. And remind me, I will tell you a story about this during class time, because I did see a patient with a very large bone met. What you'll see with bone mets is maybe bony deformation and severe unrelenting pain. So if your patients are complaining of pain, don't assume it's OA or whatever, especially if it's resting pain or night pain. If they have a history of lung cancer, make sure you're observing the area, sending them back if necessary, because it could be related to a bone met. So also important to look out for, they're also at risk for brain mets, so you want to watch for signs of central nervous system impairment. So if they do have any significant headaches, any sudden changes in motor control or balance, and if they are present, if they do have brain mets, then they are at higher risk for seizures. So, so you want to watch out for those things. So our rehab management is basically similar to what we would do for any restrictive disorder, because lung disease is mostly restrictive in nature. And often we're going to see these people, if we do see them in an inpatient setting, it'll be post-thoracotomy after they've had their resection or medical treatments, but often they're in between stages, so they may be then preparing to go and have chemotherapy or radiation therapy depending on their treatment plan. So just of note, couple of things. You want to keep an eye on their O2, their oxygen saturation, of course. They may be missing big chunks. They may have problems with hypoxemia. They may have, we'll talk about surgery next week, they may have thoracic pain due to the surgery. You have to be careful with, again, the radiation area, not to do any mobilization or massage over that area. But the rest of these things we are going to see in the lab. So we'll look at that downstairs: breathing control and exercises, diaphragmatic breathing, stacked breathing, and other inspiratory techniques, as well as using the shoulders and the thoracic spine to increase the mobility and expansion of the thoracic cage. And just to say that exercise, general strengthening, cardiovascular training are indicated even in palliative patients. There are a couple of studies that have been done, interesting studies. Patients with prostate cancer, those who were exercising regularly, actually lived about twice as long, even in the palliative group. So that's that. This slide is basically just a placeholder to remind me, to let you know that there are very many support systems for people who have had cancer. So if you are discharging patients from acute care or from rehab and you're sending them home, a good idea to think about where they're going and what kind of resources you can refer them to, because there are lots of programs available for people who have had or are recovering from cancer. So support groups and exercise groups and etc. So that's it. Thanks for listening, and see you on Tuesday.